and it's open. Oh, thank you. So this meeting is being recorded and will be posted to the 5476 webpage. It is open to the public and for public disclosure. Please do not disclose any private or confidential information with that in mind. And for those who are not committee members that wish to provide public feedback, you can let us know that in the chat so we have a sense of how much time to allocate near the end of the meeting. And then there will be designated time at the end of the meeting for about 5 to 20 minutes. Each person who wants to share will have 3 minutes to provide feedback. And if you are not a committee member, you'll just remain muted until it's time to provide feedback at the end of the meeting. If you don't have a chance to provide feedback or you would prefer to do it over email, you can submit that to hcaesb5476@hca.wa.gov. Okay. And I'll go ahead and pull up the agenda.
Are you ready, Michelle?
Yeah.
Okay, I think, Michelle, as you're working there, as we do roll call this morning, folks, what we'd like to do is, if you're present, have you state present, and then we'll get through it fairly quickly that way. We have 4 people that we would like to take a little bit of time to introduce themselves, as they have not had that opportunity as of yet. So Kevin Ballard, Hunter McKim, Kira Fisher, and Victor De Los Santos. Victor De Los Santos. The 4 of you, it's okay to say present, and then we'll come back to you and have you do a little bit more of a description in your introduction after the roll call. So Michelle, I'll go ahead and start since I'm here. I'll say present. You can check me off and then just go down the list if that works.
Okay, great. All right, so Michael.
Present.
You're present. Amber Leaders. And then I know that Ashley Jackson is here for Senator Gingras. Is that right? Ashley Jackson, are you here? Okay, Senator John Braun. Representative Davis.
Present, and I think those 2 senators are in ways right now.
Okay. Representative Jan Griffey.
Present.
Okay. Sorry, Rachel, are you tracking the attendees?
Yep, we're getting them.
Okay. Caleb Banta Green.
Good morning, present.
Victor De Los Santos. Kira Fisher. Alexi Orr. Amber Daniel.
I'm here.
Okay, great. Thanks, Amber. Brandy Flood. Cheryl Raysar.
Here.
Thank you. Chad Enright.
Present.
Thank you. John Hayden.
Present.
Thank you. Marshall Glass.
Present.
And I know Tyler is not here with us today. He's out. Hallie Bertinal.
Present.
Teresa Atkinson. Sarah Gillard.
Present.
Donnell Tanksley. Malika Lamont.
Present.
All right, and Addie's out as well. Kevin Ballard.
Present.
Hunter McKim.
Present.
Great. Representative Taylor.
Present.
Great. And Rep. Nussbrucker is out. So I think that covers everybody.
Did we miss anybody in the roll call that didn't get a chance to get off mute in time to stay present? Okay. I would like to take an opportunity before I get into the further introductions, also to recognize Jason McGill. I believe Jason's on. Jason oversees our division that manages Medicaid, and he is on here to support this group as well. And Jason, I'm not sure we had enough opportunity for you to introduce yourself in the past either. We may have, but thanks for being on this morning.
Hi there. Thanks, Michael. Thanks, all.
Yep. Absolutely. So let's come back then, and we are going to go to Kevin Ballard first. And Kevin, would you like to say a few words about yourself and the position you hold and your interest in the committee?
Thank you, Michael. I'm Kevin Ballard. I came to the committee by way of being an elected official in the city of DuPont. And basically, I grew up in Northern California. I worked in, as a student, I worked in soup kitchens and homeless shelters, and was introduced to kind of the spectrum of substance use disorder, substance use, crisis, intervention, those types of things. Later became a police officer, so I got firsthand exposure to the impact it has on families, providing life-saving measures to save people who were dealing with overdose, family members that were dealing with substance use, and having emergency personnel respond to various crises. I served 23 years in the U.S. military as an aviator. When I became an elected official, I saw the issues here in Pierce County where I live, reference homelessness and substance abuse and mental illness. So it's really in the forefront of something that I'd like to be an advocate for change. So thank you very much for allowing me to be a part of this committee. And I look forward to having some meaningful interaction and learning a lot. I'm already learning a ton, so thank you.
All right. Thank you, Kevin. Really appreciate you being here today and your willingness to serve and for what you're doing in your community already. So thank you so much. Next up, we have Hunter McKim. And Hunter, if you're on here, would you mind sharing your interest in the committee as well? You are our first youth representative, and so we have a special place in our hearts to have you with us here today, and really look forward to the insights that you will be able to share. I also have a note, and this is not just for Hunter, this is for all of us, to kind of be mindful of acronyms today. And so if you hear me talking and throwing out a lot of acronyms, do not hesitate to raise your hand or something to get my attention to spell that out. So with that, Hunter, thank you for being here. And would you want to say a few words to your fellow committee members?
Yeah, for sure. First off, it's good to be here today. Looking forward to learning a lot more about the SURSAC committee. Currently living up in Whatcom County. And what got me interested in the committee, I was originally affiliated with an interest group called the Psychedelic Medicine Alliance of Washington, and we were supporting Senate Bill 5660 for psilocybin services. And I was referred to this committee by one of the leaders of that interest group. I've always been interested in psychology and mental health. I've also known a lot of people who struggle with substance abuse. So as a result of that, I've been hoping to contribute to the solution.
Thank you, Hunter. And again, really appreciate your willingness to serve and to share your perspective with the committee members. So thank you for being here this morning.
Yeah, and then also my Wi-Fi is cutting out a little bit, so it's freezing up a bit. So if you guys aren't able to hear me, if you could just put it in the chat, 'cause sometimes I'm not getting volume. I would also like to share that a couple of years ago, I had a traumatic brain injury, and that resulted in me getting a stutter. So at times it could be difficult for me to speak. I think it'll be easier if I let everyone know.
Yeah. You came around, you came across clear, and at least from my perspective, I have Wi-Fi issues a lot of times too, Hunter. You were not interrupted, so thank you, and thanks for the background there for sharing. Appreciate it. So
yeah, that's good. Thanks.
All right, take care. Okay, let me come back then. We have a couple of members who they were going to make their first meeting today, Kiera Fisher and Victor de los Santos. Perhaps they got a little bit late. Are either of you on now by chance? Okay, Michelle, if we see them joining us along the way, alert me and we can pause and have them have an opportunity to introduce themselves. So with that, I am going to turn it back over. First of all, just a sincere welcome to everybody. Thank you for being here, particularly for our legislative members and staff and such. This is obviously the middle of session. If we picked a busier time, I'm not sure when it would be, but thank you for making the effort to be here this morning. Certainly shows your commitment, and we understand if you need to pull out for different committee assignments, as we have some of the senators this morning as well. So with that, Michelle, thank you for organizing today and planning the meeting, and I'll turn it back over to yourself for some review of our second committee, I guess, the second meeting, which was in January. So
yeah. All right, so this document went out in the email to summarize the last meeting, and it's we did our best to draw out the suggestions and feedback from the last discussion, and then to provide some resources that we have to follow up as we continue to gather the data and figure out where there are gaps, and following up with the, following up with the suggestions to look into, where those gaps may be. So in the right-hand column, there's the suggestions that came from the committee, and then in the, the left-hand column, the suggestion, the right-hand column, the follow-up that we can do, if any, right now, and then some resources to gather some more information on that topic. The only pieces that we are going to discuss today are the highlighted portions, and we can come back to the other pieces at other meetings. But the reason we're not addressing that right now is just that there's more research and information gathering needed to do before we loop back to that. But today we're going to look at the definition that we want to use moving forward for harm reduction, as well as feedback and recommendations about what to do with people that don't have beds, or there's not room for them, in that interim period, that issue that came up at the last meeting, so that we are taking advantage of that window of opportunity, that window of motivation, of readiness, and not losing people, and making sure that they're engaged when they're ready. So those are the two pieces that we have about 20 minutes to discuss right now, and would like additional feedback so that we can better understand what should be done around that. So the harm reduction definition, we'll just start there, and that's important to know so that as we talk about ways to implement harm reduction, we're on the same page about the scope of that, what that means. So I would like to go ahead and open up the discussion for what needs to be included in our working definition of harm reduction, or if there's pre-existing definitions that you'd like to use as well.
Michelle, are you showing the SAMHSA definition? Or...
I'm not. I could pull that up.
Yeah, why don't we start there at putting that up, and then we can have feedback whether or not we need to adjust that in any way.
Yeah, good idea.
Give people a chance to think about what they want to comment to while you're looking for that. So
yeah. All right, there we go.
okay, it looks like it's cutting off a little bit, Michelle.
Yeah, how do I? I'll just do it that way. We can see the whole
There
thing.
we go. Okay. I think you got it. Yeah. Okay, and if folks are calling in, I'll read it for you real quick, Michelle. If I can read it, other people can read it. So harm reduction is a proactive and evidence-based approach to reduce the negative personal and public health impacts of behavior associated with alcohol and other substance use at both the individual and community level. Harm reduction is an important part of the Harris administration's comprehensive approach to addressing substance use disorders through prevention, treatment, and recovery, where individuals who use substances set their own goals. Harm reduction organizations incorporate a spectrum of strategies that meet people where they are on their own terms and may serve as a pathway to additional prevention, treatment, and recovery services. Harm reduction works by addressing broader health and social issues through improved policy programs and practices. So I think the first paragraph is sort of the definition, and it talks about how to implement a bit. So I'll go back to that first one just for one more time. Harm reduction, proactive and evidence-based approach to reduce the negative personal and public health impacts of behavior associated with alcohol and other substance use at both the individual and community level. So that's, I think, that first paragraph is what we're looking for comment by. If we can, if we all want to align with SAMHSA and say, okay, let's move on, we can do that. If we need to tweak it a little bit, that's, I think, what Michelle is looking for feedback on this one.
Yeah, Malika.
Why wouldn't we use the National Harm Reduction Coalition's definition for harm reduction? And there's principles of harm reduction that go along with it. Kayla put that in the chat. I actually was, before I could, but I just feel like, I mean, that should be primary. What SAMHSA thinks is great, but we should do it according to the people that, you know, have developed. This is a movement for people that, you know, use drugs, by people that use drugs. So I feel like that would be the better thing to do. We can include SAMHSA, but the government has not always supported this movement.
Okay, and Hallie? Thank you, Malika. I'm pulling up that definition now from the link that was shared. Sorry, go ahead, Hallie.
I have one thought, and it's in regards to both the SAMHSA first paragraph and the principles of harm reduction site. And that's that I know that in our work here in Spokane, I've talked about it before, that there's a perception still that harm reduction isn't a valid approach. And so the word negative really jumped out at me on both website descriptions. And so I wonder about using something like harmful consequences rather than negative consequences.
Yeah, thank you, Hallie. Let's see. Any other thoughts about switching out negative for harmful or consequences? And I've got the National Harm Reduction Coalition link pulled up right now, so I'm just going to go ahead and read that definition. At least at the top, it says harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. All right, so, sorry, Malika, did you have another comment? No, okay. Okay, so if we were to use the National Harm Reduction Coalition definition and swap negative for harmful consequences, would that would be a good working definition to consider?
Michelle, I think that Brianna's hand's up, and then also if you could share, and I'll
put that one in there too.
Here, but if we can, yeah, if we can share the other, so we can all look at it at the same time, that would be helpful. Brianna, go ahead.
So I'm just like reading through the chat, and they're saying like that Caleb said harmful seems to be a substitute for negative. And I also looked at the definition from the coalition, and I think like I think we can maybe combine them in a way and then just remove the negative, just saying like harm reduction is a proactive and evidence-based approach to reduce the personal and public health impacts of behavior associated with alcohol and other substances, and also add that it is a movement for social justice based on the belief and respect for the rights of the people who use drugs, kind of thing. Does that make sense?
Yeah. Yep, that makes sense. So, okay, so we can basically combine them, take out the word negative, and I can try to do that just, right now. And as long as there's not, I guess, objections to that, then we can go ahead and move forward with that definition. Unless people would like some more time to think about it and consider it. So I can put that together later and report that back to everyone, but I think we're on the same page about what that would look like. It's a combination, take out the word negative. Okay, so we have, let's see. We just have about 5 minutes to go over this next piece. So we'll see how far we can get, and then we'll have more time for discussion later in the meeting. But to start talking about how to help people that are in that window of readiness, but not getting into treatment right away. Want to open up discussion for ideas for how to keep those folks engaged until they're able to get into direct treatment programs.
And I'm sorry, Michelle, I just want to pop in. Then we'll have more time to elaborate on the discussion later as well too. And also I saw one of the attendees that was not here earlier popped on, Kira Fisher.
Oh, great. Should we use the next 5 minutes for introduction from Kira then?
Yeah, let's do that.
Okay. Great, we can come back to this later in the meeting. All right, welcome, Kira.
Hi, can I just have 1 second really quick so I can take somebody back? I'm at work at the same time.
Sure.
Just like 2 seconds.
Yeah. Okay, and then following Kira's introduction, we will have a short presentation from Third Horizon Strategies on the asset roadmap to recovery asset mapping tool. Just want to confirm Greg and Ashley are on.
Yes, I'm here, and I think Alex is here too.
Okay, great.
Yeah, hi everyone.
All right, hello.
Sorry.
Oh, no worries.
So I don't, what do you guys want me to say?
Just an introduction about your interest in serving on the committee, the role that you're representing, and anything else that you would like to share. But
okay,
yeah,
I'm Kiera. I am an addict in recovery, and I have spent my whole life in addiction, and you know, I've been incarcerated over it. It's completely, I mean, I got my kids taken away because of it. It completely changed my whole entire life. And I now have almost 18 months clean, and I work in a treatment facility now, a brand new treatment center that's opening out here in Arlington. And yeah, so I'm really passionate. I want to, you know, I want to change. I mean, I want to do my part and what I can to help change, you know, the community's view on people, you know, who are in that population, and yeah, do what I can to show that, you know, we can get clean and recover, and that it's a possibility. They just need the support behind them.
Yeah, thank you so much for being here.
Mm-hmm.
All right, so with that, I think we'll hand it over to Greg, Ashley, and Alex at Third Horizon to tell us about the Roadmap to Recovery asset mapping tool. And do you have screen share capability, or do we need to hand that over to you?
If you can hand it to Alex, that'd be great. And Brianna, did you want to tee the conversation up, or you wanted me to dive in?
Yep, I'm ready. So good morning, everybody. I wanted to introduce Greg and his wonderful team. As we've been having discussions about what's going to go into the plan, we were looking at previous work that's been done, and there was quite a few things that were done in the Roadmap to Recovery based out of a grant from CMS back in 2019. And Greg's team is building a tool called the Recovery Readiness Asset Tool, which is a web-based portal that's going to help MCOs and providers and policymakers figure out where some gaps are and different aspects of recovery, and help them make decisions in the future. And I thought that this might be a good tool, as some of the requirements of the plan might align with what this tool has to offer. And so I wanted to have them here to kind of show what they have been working on. And I also sent everybody, actually Michelle sent it with the agenda, a document that also has some more detail about this tool as well. So if you guys take a chance to read that at any time, you guys can let us know and make comments on it. And I'll hand it off to Greg and Alex.
Well, thank you, Brianna. And it's great to be here. My name is Greg Williams, and first and foremost, a person in long-term recovery. And thank you, Kiera, for sharing your story and participating in this group. It's been a privilege working with Washington State over the last year and a half or so on Section 1003. Our primary objective for that work with the team was to develop an alternative payment strategy for addiction treatment and recovery support services, getting at some of the social determinants of health and other kinds of things that the Medicaid fee-for-service program isn't purchasing, and thinking about structures in a way that payment could start to create alignment and in proximity for people across the continuum of care. There's so many services out there, and some of them are just fragmented and not connected well enough. And so part of the goal of the alternative payment structure was to align with the state's value-based payment targets, but also to try to incentivize the provider networks and the MCOs to try to figure out more alignment around people traveling across the continuum of care. And as that work progressed, the state asked us to develop some tools and resources for providers and MCOs if we did go to implementation of the alternative payment model. And as a result of that, we had defined a number of services and service sets that could be a part of that, and wanted to kind of create an interactive tool that in theory, policymakers, MCOs, and provider networks. And so what we'll show you in a minute wasn't necessarily originally designed to be public facing or for end user use cases, but more from a system level perspective about how to assess market capabilities and capacity. And where an MCO says, I want to organize a cluster of providers to deliver a comprehensive continuum for this kind of alternative payment, I could draw a circle on a map and start to see the different kinds of providers. This is still in a beta form, so we're working through some data stuff around how providers are listed from a geographic standpoint in Provider One, as well as also we're starting to get into Department of Health licensure data. So the data outputs that you will see are not fully comprehensive. Just so you know, it's built on Provider One data, and unfortunately, Provider One data does not capture the geography of every provider in the state that is licensed for Medicaid. A lot of providers work as a large cluster, and those pull up to their billing address and not necessarily their service address. So the data is a little skewed in that fashion, but we're working through kind of ways to mitigate that. And I'll turn it to Alex now to kind of walk you through where we are and what the tool looks like now in the context of the use case that we had previously. And obviously Brianna teed up the conversation about what a different use case could be for the general public and for public facing use cases. Can you share your screen, Alex?
Sure, thanks, Greg. Yeah, let me do just screen share here. So if everyone can see that, maybe I can minimize that. So here's the tool when it's loaded. I'll just kind of go through and show you guys a couple of the cases, but again, as Greg talked about, we designed this for managed care organizations to kind of be able to see what are the assets in their area. So if you take, the Spokane area, you can select then counties, and you'll see, well, what are these assets that are here? And they're segmented into categories. So recovery support services, outpatient, et cetera, and you get this map view where they're easily viewable. And you also get a list view underneath. So if you want to know, okay, where's Compass Health, there it is. This is all searchable. We have kind of going back for the whole state, just a couple layers, so you can see kind of how things map, drug death rate or percent uninsured, things like that. And then also another view for, kind of to drill down a little deeper is to go by county and zip code. So for the King region, you have King County. You can see there's a whole lot of assets in there. So maybe you're only interested in, let's say, one zip code, and you can go and you can see, well, okay, what are kind of the distribution of assets within that zip code? If you don't want by zip codes, we had thought of still a third case of just selecting a location on a map. So again, if we're here, you select a location and, within, let's say, 15, 20 miles of that location, you'll get, what are the assets there. So maybe, whether that's person or a place, and you want to know, well, what's within kind of their activity space, you can use this tool for that case. And again, we're going to have, maybe I can do a case where there's sort of more things going on, you'll have them counted up for you, and then you're going to have them all in a list view. One other use case that people had asked about, so I'd also like to show it, is not just kind of point and click on a map, but can you do a search either by address or by landmark or something like that on a map. So I can show you all really quickly, because I did kind of a dummy example using some recovery support data from Illinois that we have, but this uses Google search. So it's a very powerful tool. You can kind of put anything. There's a Midway Airport, it takes you right there. And then, if you want to know, okay, well, what's peer recovery support near there? Here it all is. And, it'll even show you by inventory view, sort of how the distance, what's the closest thing to the location you put in. For example, if we get out of Illinois back to Seattle, there we go. And I mean, you can see how good the tool is. I spelled Seattle wrong and Google still knows what I'm looking for. It'll take you right to the address. So that's, I think, for an end user use case, maybe something, we can also do. But okay, going back here, the rest of it, I won't spend too much time on. This was some analytics we tried to do with the data that we had, doing some clustering to see, what counties were kind of similar to one another based on, different markers, and going down further, some mapping views of that, and then also just your kind of claims data that was mapped out. But again, the analytics are only going to be as good as the data that goes into it. So I think I'll stop the share at this point and maybe see if people have any questions about it, comments.
Yeah, thanks, Alex. And I see Jessica just asked if it's still in production phase. I think all of the roadmap to recovery, I don't know, Chris, if there's been any decisions about the deliverables and publicity of the deliverables, but they haven't launched yet, but certainly it's available kind of in a beta phase. I don't know, Chris, if you had any thoughts on that in terms of launching this version. Part of it is getting at this data issue that we're still trying to navigate around the lat long of the Medicaid providers, which kind of has been a longstanding issue, I know, in the state. So we're trying to solve for that right now before we would go public with any tool.
Greg, I would just agree with you. It's in a pre-production phase still, but I would say it is somewhat close to being where we want it to be so that folks can start using it. And like you said, we have some data quality issues to work out before it's ready to be like really launched, but we're working on those.
Greg, if I might, this is Michael. I see a lot of hands up, which we want to hear from the committee this morning. I think that we would want Medicaid and non-Medicaid, we want all providers, whether it's treatment, recovery supports, outreach, all those things, right? I don't think we should spend time on that other than to say we want it all. But if the committee members can let us know, based on what you saw this morning, your thoughts about that, the possibility of it coming live, and then what else would we want to see on there? What would you like to see in a tool that would help navigate where resources are? I think that's the type of feedback we'd like to see this morning. So I'll go on mute again. I see lots of hands up.
Go ahead, Caleb.
Great, thank you. Two things. Hi, Greg. both for Greg and maybe for Michael or folks at Healthcare Authority. So we've done a lot of work on similar types of things for over a decade. And what I'm curious about is what you think the resources are to actually keep this current on, say, a weekly basis. And as for folks to see this, and I want to sort of share my lessons learned, is it's one thing to create an annual directory. That's one thing. It's another thing to create something that on some time frame, daily, weekly, monthly, is actually current, which you actually need to manage work and refer clients. And an example of that is the Recovery Helpline's buprenorphine locator, which we've spent over 5 years building. And I've learned a lot. It's very hard to keep those things current. In fact, you really almost can't. And that's got 2 staff people just trying to keep things roughly current on, I don't know, something like a monthly basis for one narrowly defined scope of service. So it's a lot of resource to do that. So I have a 2-part question. Part is going to be to Greg, like, have you seen this implemented? And in a county of 500,000 people with 500 providers, how many staff does it take to maintain a directory like this? And at the same time, maybe to Michael, other folks at Healthcare Authority, in some ways that is only useful in the context of a closed loop referral system. And what the hell does that mean? What that means is that providers across healthcare and social services can actually communicate, and you can follow a client through all these systems without having to assess people to death and re-traumatize them with 6 assessments in a month. So what I'm trying to get to understand is where the state is, what's going to happen at the state level, what's going to happen at the local level, both about these sort of resource directories and how they fit into actually these referral systems. I keep hearing pieces and parts of it, but I just haven't heard articulated how this all comes together to be of service to people. And that'd be really helpful for me. And I hope this committee, as we have 10 months to ostensibly figure this out, and we need to know the infrastructure into which all of this work and definition plugs in. So I don't know if Greg could speak about, any actual place this has been done and what it takes to really do this. And if Michael or somebody else could speak about how this fits into an actual sort of functional system of care where people know how and where to send people.
Actually, really quick, right before you, Greg. So I just wanted to pop in is that there's a bill that passed 1477. It talks about behavioral health and suicide prevention, but we've had discussions with them, and they are talking about including SUD and recovery support services as part of gathering their data on a daily, weekly level for capacity. So there is stuff happening here at the state that we would probably have better data moving forward.
And I think it's a great question, Caleb, and it is the core question of any resource application. Building the front-facing application and the features is definitely the easy part. I think what we've seen done and have done in a couple different use cases, not exactly in this state-based use case, but the team Alex is on with Chris Hart. They did it for Google, pre-COVID, Google Recover Together. They had a live updated recovery support national tool that now they weren't maintaining the list currently, but they built electronic pipes, if you will. I could use more technical terms. I'm starting to learn from Alex and Chris the technical terms, but effectively like na.org, right? So NA updates their list on their website nationally, right? And so you build a scraping tool that effectively takes that information and then populates it in the application that you want. So in this use case, the vision is that you would be taking provider 1, DOH licensure data, the recovery helpline data, any other resource that is already maintained within the state. However, whatever form that is, if it's on a spreadsheet, if it goes up to a server, you build back-end infrastructure to then take that data and then code it to the front-end application. So it's not a perfect solution. You still need the resources on the ground to update those lists, whether that's DOH's licensure list or provider 1, claims data, registered providers, or commercial providers, as Michael said. But the idea is you'd build a data warehouse that would have basically arms and legs to these data sources, scrape it, and then populate it on the front-facing application. And then the same with recovery support services. So it's definitely not a perfect solution, but it's kind of the best of what's possible. And we've seen in other states, you know, there's some bed resource tools, there's other things that do certain things. Nobody yet has deployed it where they put the entire care continuum, soup to nuts, together in a tool like this. So this would be a brand new, you know, deployment of something like this.
Caleb, I'd like to respond real quickly too. I think today is more about visioning, quite honestly. We could find a lot of ways of why this is going to be challenging, right? And you articulated several of them that came to my mind first too, like who's going to populate this and how frequently and all of that. I think today, in response to the bill or to the plan requirement and to the need, more importantly, we want to find a mechanism that we can start building from and building on. And we don't have all the answers today, but we'd certainly like to hear what you all would like to see in a system, and then see if we can realize that. Jason kind of just sent me a note on the side. Certainly there's a lot of care coordination that happens with MCOs and BHASOs and accountable to communities of health and so forth. And so there's a lot of resource lists and things out there that we can kind of bring into fold as well. But let's hear about folks, get other voices in here in terms of whether or not this is something you think would be useful, who it would be useful for, and what you would like to see it entail. And then we're going to have to do some feasibility to work to see whether we can do it and how quickly we could bring it online and what resources might be needed. So others?
Yeah, Holly, do you want to go ahead?
Hi, yeah. So I want to make sure I phrase this in a positive way, but this will be the third calendar I've been involved with, website specific to help navigate services. And we currently have a local foundation working on one specific to Spokane. The Spokane Opioid Task Force spent a ton of money creating a website. And for me, my gut response is actually anger. And I know that sounds weird, but I look at the amount of resources that I have personally watched go into this and what we as boots on the ground people could do with those same resources. And it's actually kind of infuriating. I get that the intent is good and that we need resources. The reality is, I think for those of us that are service providers, we know our local resources. And for those that are deeply impacted and in the midst of active substance misuse, they're not in a state of mind to navigate that typically. So I think the idea of figuring out what resources we have and where we're lacking and how we need to improve system delivery, especially through the perspective of harm reduction, is very important. But I have a hard time wrapping my head around the amount of money I know is going into this project. So that's my from the gut feel.
Marshall, do you want to go ahead?
Sure.
By the way. Yeah.
And I agree with a lot of what has been discussed so far. For me, as the managed care representative, I mean, a couple components. One is it would be really crucial to actually understand which of these providers are contracted with which MCOs. And then from a commercial standpoint, I mean, I know how difficult it is for folks that have private insurance to actually navigate providers and then be told, oh, this is the perfect provider, but we're not going to take your insurance, or we do take your insurance, but we don't take this type of private insurance plan that you're on. So being able to really incorporate that specifically into the tool would be really helpful. I know just as a person in recovery myself and having worked with so many members of the recovery community in seeking, and this is more so private insurance services, it's really hard to get your heart set on a place and then be told that the out-of-pocket expense is going to be ridiculously high. So maybe a way to incorporate some of those components. And then lastly, I mean, one of the big issues that, of course, we're facing, not just in Washington, but throughout the country, is capacity concerns. And so I'm wondering, I know there's been work done for bedded levels of care on capacity, but from an outpatient standpoint, I'm wondering if there's a way to integrate capacity, real-time capacity data, because the reality is it changes so drastically and so quickly. And as managed care organizations, we do put a ton of effort into collecting data from providers so that we have information and where to direct our members to services. But the data changes rapidly. It could change from morning to evening even. So I also understand provider bandwidth. And so proposing that providers have the ability to actually enter data into some sort of portal is, especially given what everybody's experiencing right now. I mean, that sounds like a pipe dream, but something that I think is important to consider. Thank you.
Amber, did you want to, thank you, Marshall. Amber, go ahead.
Thanks. Let me put my hand down before I forget. I was just gonna say, is there a way to maybe make a feature on this tool to where it can report where gaps are in services in an area? Like, how many times did I search for detox in Walla County and find nothing? And that was one thing. And then, you know, of course, based on what I heard from Marshall and Hallie, I had thoughts of like maybe having filters for insurance or price ranges or whatever, like search filters. And then maybe this is related and maybe it isn't, but I just know that there's a lot of faith-based treatment centers, and I'm not a proponent of those, but they have a lot of beds and they don't get that state money. And I think that it's a really underutilized, like, you know, as long as it's okay with the patient, you know, I think that it's maybe harder for them to be like, to get any kind of funding, you know, and maybe if we were able to make it easier for that to happen, like reevaluate the criteria to where it was more like recovery based instead of treatment based. I don't know if that makes any sense, but I think that could solve a big problem. And that went a little off topic on the last part, but that's all.
Thank you, Amber. Yeah, those are excellent ideas from everybody and a lot of great things to think about. That does bring us to time for that piece of the agenda. So yeah, again, thank you so much everyone for your contributions to that discussion. And now I'm going to hand it over to Michael to facilitate a conversation about where and what type, this is related of course, but where and what types of new community-based services are needed, and to get the committee's feedback about that piece.
Thank you, Michelle.
Oh, and again, and thank you to Greg and Ashley and Alex for all that wonderful information and presenting on the asset mapping tool.
Yeah, I think what you're starting to experience here in these meetings, folks, is you're getting sort of snapshots of ideas or thoughts that we need to go through as we think about a plan, creating this plan. So if you have ideas about this tool that we're asked to look for, a resource tool that folks can use, by golly, if there's something out there already that we're not aware of, we'd love to look at that. If not, then we'll try to create something that is most useful, most current, and as economically as efficient as possible. To Hallie's point and other folks' points here, we'd rather have services, those direct services out there to the highest degree possible, but we need some of this infrastructure. It's called for in the plan or in the law, and it's also something we find would be helpful. So anyway, I guess I just transition all of that saying, if you have more ideas, send those in, and we'll give that consideration as we think about how to move forward. This next part will spend about, actually, I think we have most of the hour. We have about 50 minutes, I think, to talk about resources that you would like to see in the community that may not be there now, or if there's something that's there now, but you just would like to see a whole lot more of it. This is time to start collecting that information as well. And we'll break this out into 3 areas. We know they're overlapping and they're intertwined, and nothing is cookie, is completely cookie cutter, but we're going to start off talking about outreach and engagement. Now, this might be helpful from what we talked about last month, which is, what do you do when somebody's waiting to get into treatment, if that's the path they're taking? What can we do when that window of opportunity is there and we want to offer some supports? What might that look like? We'll spend about 20 minutes on that, and then we'll look at treatment itself. For those that choose treatment, what kinds of treatment capacities do we need to build more of, or new models that we might want to take into consideration? We heard Senator Dinger talk about, going global. What's happening around the world, really, that in the treatment space that we might want to consider looking at here. And then finally, recovery support services, which we know intertwine throughout, but just make sure we're capturing all things that might be considered recovery support services. So we'll start off with outreach and engagement. And if you have ideas about what you'd like to see in your community, whether that be Walla Walla, Reardon, or Raymond, let us know, and we'll start taking down some suggestions and ideas. Would love to hear from all of you. If you haven't spoken up yet, please consider weighing in here. And we'll start with hands that we see raised. And looks like first up we have Amber. Do you want to go ahead and give us your ideas, Amber, in terms of outreach and engagement that you'd like to see in your community?
Yeah, I actually had an issue recently where I had a peer that had been like drinking for 7 days in a row and hadn't eaten in 5, and had a plan. And as a mandated reporter, I had to report that. And the only service in my area was a crisis management person. When I called 911, a crisis management person came, but they were a voluntary only crisis management person. And that's all that we have in the area. Also, the only, we don't have a detox at all. I like to see crisis management and withdrawal management services, at least here in Walla Walla. There was really, I was by law reported to mandated to report this, but there was nothing anyone could do. They told me if I wanted to take him to the ER and sit with him the whole time, that was about all I could do. And then I would be responsible to sit with him the whole time. And as a peer support person, that's not really appropriate for me to transport. And now with the, where the police don't have to transport, and neither do the paramedics if they don't want to, that's the new thing. And they can choose not to. And I think that it doesn't do any good if I have to report it if there's nothing that anyone can or will do.
All right. So more voluntary or involuntary crisis supports and detox is what I heard Amber you say for the notes. Does that make sense?
There's also ways to do withdrawal management where people can manage their withdrawals at home with medications and stuff like that. Like, there doesn't have to be a facility all the time.
Okay, thank you. Hallie, it looks like your hand is up, unless it's from before, I don't know.
I lowered it and raised it back up again. One of my first thoughts, on this topic, when I think of the biggest pain points that we run into when someone is ready to jump in and do recovery in a major way, they're like, you know what, I've been trying harm reduction, I've been doing this, I've been doing that. I suddenly want to like dive in and do like abstinent-based recovery. Then there's the challenges of getting a bed and providing support so that the person stays in that state of change that they're in. And I think, I don't know if it's feasible, but I think peer respite as an option could be a really beautiful thing. Because then you're in a supportive environment with peer counselors while waiting to get that bed. So just a thought, I know that's a major ask, that's no simple thing, but I think it could be a game changer for a lot of people.
Hallie, I missed your first, you said something respite. I missed the first word you used there.
Peer respite.
Peer respite, okay, yeah.
Yeah, and then I wanted to say regarding, I want to second Amber on we have withdrawal management here, but it's just never really enough. So that's a challenge. And then we have no true medical withdrawal management. And I work with people often who just will not go to withdrawal management because there's not access to meds to help gentle that experience up a little bit. You know, and when you think of substance misuse, it's often related to trauma, which is, you know, you're using to not feel these really painful feelings. And then we expect people to go into withdrawal management and like, it's like, let's strip all that away that's helping you deal with these feelings and leave you with kind of nothing. And in withdrawal management is not the most comfortable place to be typically anyway. Like it's not set up to be very comfy. So it's a hard situation to put people carrying untreated trauma into. So just a thought.
Thank you. It's really important. While folks are thinking about how to formulate their response in terms of outreach and engagement or pre-treatment kinds of services, also think about the different populations, right? Whether you're a young person, an adolescent who needs to come into care, perhaps someone in the retirement years that, you know, now they're facing this issue, they need to come into care. Someone who is pregnant or has a young child or baby, whether it's a man or a woman. Just think about the different populations that we're serving and what we may need to put in our communities to help with that engagement and outreach and sort of pre-treatment. So other thoughts and ideas? I've seen, let's see, I think Alexi, you had put something in here. So other thoughts and ideas. Karen, perfect, your hand is up. Love to hear from you.
Hi. So when I was getting clean and sober, or when I was trying to, me and my husband together with our child, they didn't have any treatment facility where me, my husband, and our child could go together. They wanted to separate us. So I noticed out there in the community that a lot of people have a hard time getting clean with when they can't go with their, you know, with who they're trying to get clean with and raise their children together and learn how to be clean together. So that was our biggest obstacle when we were getting clean. So I think it'd be really cool if maybe they, you know, had more places like that for people like that.
Okay, thank you. We'll throw that in the treatment bucket, but certainly if there's things that families can do in that sort of engagement phase too, what you're saying is let's let the loved ones come together, not separated. So,
yeah.
Thank you. Appreciate it. Alexi?
I just want to say on what Kira said, that I come across that a lot where kids come in and they want to get sober with someone, they want to get sober together. I don't particularly think that that's the best idea always, but if they're a family, I could see where that is a thing. But for me, where I'm finding the most problem is finding detox. it's like, I live in a small community. So there's, I can get like medical, medicine for them, but there's no place for them to go without driving 3 or 6 hours. And then if you have a youth who's under the age of 18, it's even harder to find a place for them to detox. And it's really frustrating because the kids are scared. They're scared to get sober. They're scared of the pain, and they really need a place where they are taken in, treated, like human beings, and given some comfort and a real a detox situation that will work before we can get them into treatment. And then of course there's always the treatment problem and waiting for a bed and having to be ready to go on the fly. It's like there's no sense of in planning. It's like you call one morning and there's either a bed or not, and it's difficult to get someone together in a matter of hours to drive 6 more hours, where they're going into withdrawals and like it's just it's hard when there are no resources close to you, and the closest thing for us is at least 3 hours away, and that's daunting for me and for the youth.
Okay. Alexi, thanks for the words. If there is something, whether it's withdrawal management or even after withdrawal management, where you're waiting to get into residential care, if that's the route the patient wants to take, if there's any service that you can think of while you're waiting for that bed to open that you'd like to see in the community, give that some thought. We'll come back to you if you have some ideas, and or put it in chat, and we'll continue to build on those ideas. But thank you. And remind us one more time, you're located where in the state? What community?
We're in OMAC.
OMAC, okay.
So Eastern.
Right. Yeah, thank you so much. Looks like Marshall, you're up next, and then Hunter, you're on deck.
So this is more general, just with recovery, and this does speak to Malika's statement. As we know, recovery and community are synonymous. It's really tough to maintain recovery if community isn't there, and it's not spoken about enough, but there's huge stigmatization with harm reduction in the 12-step community, which happens to be the most accessible and widespread community that exists. And then beyond that, within just housing communities in general, just sober support housing. As we as treatment providers and managed care really, and with legislation and everything are progressing to view harm reduction in a different light than it was viewed historically. The sober support communities in a lot of ways really aren't. And of course there are other options, but they're not nearly as widespread. And I don't know specifically what we as a committee can do to combat that, but I can't tell you how many times I've come across folks who are terrified of sharing that they're engaging in harm reduction services as they're going to 12-step meetings, because they don't want anybody to know, because people are going to view them differently. 100%, not everybody, but a lot of people are going to judge them. And when we have a program that's just recovery in general, built upon being transparent and being honest, and then not feeling comfortable actually sharing what is going on specifically with different harm reduction practices, I know that can be really tough and has resulted in relapse more times than I can count. So that's just something I want to throw on the table as well. Thank you.
Thank you, Marshall. Appreciate the comments. Hunter, if you want to take yourself on mute, we'd love to hear your thoughts about outreach and engagement, maybe around young people, but you're open to give your thoughts on anybody.
Yeah, so I guess this kind of pertains to recovery a little bit more. So I went to a wilderness therapy program a couple of years ago. It was located in Utah, and I found that experience to be really helpful. And I don't think there's any programs like that here in Washington. I think that withdrawal from society was helpful, kind of regaining stability. But what I think is difficult is when you kind of reintegrate back into society. It's kind of difficult for your mind not to relapse, whether that's trauma or just stress that occurs every day in society. So I think that the withdrawal from the original environment is good, but I think that services to reintegrate are also really important as well. And I think that's what a lot of programs like 12-step could do, because you have support and people who are going through similar experiences as you are.
Thank you, Hunter. Really appreciate your perspective. Folks, we have about another couple minutes on the outreach and engagement, then we'll move on to treatment. And that's okay. Some of this is kind of moving in both directions, but any other thoughts on outreach and engagement? Particularly folks who maybe haven't had a chance to speak yet. I'll make sure I'm not missing hands here in any way. Clear across the board here. Alexa, your hand is up. I don't know if it's back up or if it was up from before, but you're welcome to speak if you have an additional comment. Oh, looks like you took it down. The only other hand up I see is Hallie. Did you have yours back up? Okay, go for it, Hallie.
I just wanted to mention really briefly that it hasn't been mentioned. I think it's because a number of us in here is just part of our everyday work, but that focus on peer support, certified peer counselors in general within that navigation time, well, throughout the continuum, truthfully, is really important. But I think that certified peer counselors are the most powerful tool out there to support people who are walking through that really difficult navigation process.
Thank you. Boy, we've certainly come to rely on our peers a lot. So thank you for bringing that up. Absolutely. And it looks like Malika, you've got your hand up as well.
So I'd just like to mention that, like if we are focusing a lot on whether or not somebody is using drugs, but we also part of our charge is to look at the social determinants of health. And, as a potential, body that can influence policy, when we're looking at different entities that are doing work or that could do work in a really profound way that would impact people's outcomes as far as like housing, what type of agencies get housed, that's something, or get funded, excuse me, that's something I keep hearing. And recognizing that using substances is a response, as people have said, to trauma. And we have a number of things that are, if a person doesn't have a place to live, if they don't have a community that makes them feel safe, and if we're not looking to provide ongoing support for that person, we don't pay for outreach in a meaningful way in this state. So it's like, it seems to me that could be a place that we look at for a recommendation. This is the first time that that's ever happened. And looking at the different ways that we need to engage in outreach, working with all of the different populations and where those gaps are. And like, that's too much for us to do in a short conversation, but I feel like that's something that we could break out in all the different areas that are impacted by this 5476 and by the Department of Health and Healthcare Authority, and then identify where all the people in this group think that funding should be redirected, or just to bring, that it seems like part of our charge. But social determinants of health impacting that, that's how people get to a place of more stability.
Thank you, Malika. That is in part what we're starting here. We're starting the conversation. We're going to transition over to treatment now, which is about drugs. And then we're going to come into recovery support services, which will get in a lot of the social determinants of health. Malika, one thing I picked up what you said is that this is a teaser a little bit. We're just scratching the surface. Outreach and engagement, what else is there? That's what we started hearing a little bit from you this morning. If you have other ideas, put them out there. If we need to set up some subcommittee work to look at outreach, treatment, and recovery, we can do that as well. Let's go ahead and transition now to treatment. And for many of you, you've had experience trying to help loved ones or help folks you serve through your workday access treatment and also understand the type of treatment they're getting. For others, we have lots of folks on here who have participated in treatment, and that's worked really well for them, or they've had challenges. So I expect some lively discussion about what would you like to see in your communities throughout the state. Maybe start in your hometown and kind of broaden across the state. What would you like to see in terms of treatment that we may not have now, or we could use more of that we have now? And again, please look at the lens of all ages, all ethnic communities, all genders, everything that we want to look at in terms of who's coming forward for treatment. So any thoughts about what you would like to see in the treatment space that we may not have? Amber, it looks like your hand is up.
I was trying to give other people a chance to go, but I didn't hear anybody talking. I know I've been very vocal. I'm not trying to dominate the conversation. I just, I know as far as what Alexi was saying about housing for youth and stuff like that, there's nothing for youth here. And it's mainly because of the laws around what we can do with youth. And the problem in my community is that these kids are like second and third generation gang members. So even though their parents are, you know, we have to notify them. We can't house them for more than a certain amount of time without notifying their parents. We do have like one youth shelter, but it's very limited, like what they can do. And as far as, so I'm seeing all these kids because I teach a recovery group in the juvenile hall here, and I'm seeing these kids just getting recycled through jail because they don't have access to services, and it's like their second home until they age out, you know. And that's so I think especially in a rural community like Walla Walla, that and medically managed detox and withdrawal management, trauma informed, you know, as far as we don't have anything, people have to go to Yakima or to Spokane to go to detox. I mean, there's one in Pendleton, but they won't take Washington Apple Health.
Okay. Amber, I'm gonna, what the right word is here, probe this a little bit more. If you could have the ideal treatment options available in Walla Walla, what would that look like for you?
It would look like crisis management services for youth and adults that are primarily substance use. The only one we have in town is a primarily mental health place. And they accept people with substance use, but they can't manage any sort of withdrawal. And so they don't accept people that have the possibility of DTs or withdrawals. I would also like to see housing, permanent supportive housing model integrated into some treatment around here. There's none of that, zero. As far as like Oxford housing, we have like 2 men's and 1 for women with children. And that's, you know, anyways, yeah, if it was perfect, it would be, and there would be peer support that would be in place from the entrance into recovery all the way through the continuum. So they have some sort of consistency as far as, you know, continuum of care. You know what I mean?
Okay. Thank you. Appreciate it. I see a couple more hands up. I am going to encourage folks that may not have had a chance to speak up yet to think about if you could put the best treatment in your town, in your neighborhood, in your community, your county. What would you like to see that you don't have now? And give that some thought. We'd love to hear from you. We have another 10 minutes or so to go on here. I'm going to go to Alexi next.
I think kind of along the lines of what Amber was talking about is like, what do we do with these people when they get out of treatment? Because if we don't have housing in place for them or some sort of transitional situation, they are going to just be released back into the same neighborhood, the same group of friends, the same people that they were just left. And I think that really brings down their chances of like long-term recovery. And being able to have someone have their basic needs met shouldn't be so difficult. You know, we're putting homeless youth up in a hotel, and it's like they're just hanging out with all their friends and drug dealers, and like there's just nothing else we can do for emergency shelter, you know. And I don't want to put someone in treatment and put all that effort in to get their life together just to put them right back in that situation when they are released. So I think there has to be, yes, some transition before they go into treatment to start the process of getting them, you know, to sort of be able to see the end result and where they could go after treatment. And just having, yes, from start to finish, more of a plan and a place for these people to go.
Thank you, Alexi. Appreciate the comment. We see in the chat, Marshall talks about true co-occurring services being available in treatment, incentives for master level clinicians to pursue SUDP certification, vice versa. So really kind of broadening out the treatment experience. Marshall, if I've got that right, I don't know if you want to add anything.
Sure. I mean, really for me, what it comes down to is that we have a lot of integrated providers, but oftentimes the SUD services and the mental health services are done. It's not the same groups, it's not the same individual sessions. And, you know, as we know, finding a dually credentialed clinician is like finding a unicorn. So there's not a ton of incentive for somebody who is a master's level clinician to pursue an SUDP certification. And I mean, for a lot of folks who are SUDPs, the path to master's level licensure is, I mean, it's terrifying and long and costly. So what are some of the incentives going to look like there? Because at least in my experience, there isn't a significant salary increase for folks that are dually credentialed, despite all the work that's put in. And I don't know if that's something that we can discuss, but some incentives could greatly assist with that.
Thank you, Marshall. Appreciate the comment. We'll have to have a conversation about workforce here at some point for sure. Representative Davis, we haven't heard from you yet this morning. Welcome, and please share your comments.
Thanks. Good morning, Michael. Good morning, everybody. Couple thoughts around treatment. So one thing, and this is consistent with some of the comments that were raised earlier, I've always been fascinated by the concept of looking at an SUD peer crisis respite. We don't have any. The peer crisis respite model is pretty new. It was sort of officially created under a Schmick bill from a couple years ago, but I would love to see, it's sort of a pie in the sky idea, and I wonder if we could pull it off. But the concept of pairing ambulatory detox with a peer crisis respite. So you would provide outpatient medications and then have them, the patient self-administer the medications in a short-term setting stay that's staffed exclusively by peers. So that's, feel free to tell me it's a terrible idea, but it's something I've spent a lot of time thinking about. That's the type of thing we could scale pretty quickly. And the reason we could scale it is you essentially use a single family home, and single family homes get you around the NIMBY issues. They also get you around construction because they already exist. And generally speaking, we don't have the same kind of zoning issues that you run into with local governments for that type of use case. There are a couple treatment providers that have used this successfully over the years. There's a now defunct treatment provider that used to be called Sound Recovery that got bought up by Royal Life Centers, but they actually use single family homes and they had a phased treatment model. Hotel California by the Sea, also their detox is actually a home. It's a single family home in Kirkland. So I think that model is attractive, SUD peer crisis respite. The other thing I want to talk about, this is not going to surprise my friends at HCA because I've sponsored several budget provisos related to this, but I really think we need to pay attention to the quality of treatment. So, standard SUD treatment is, your 28 days of inpatient and then your 8 to 12 weeks of IOP, but looking at like, what are we actually teaching people? What a gift we have of their time and for them to be there for that and their willingness to be there, and how are we using that? And there's so much just incredible innovation out there that I don't feel like has made its way to SUD treatment. I mean, we literally have providers that play VHS videos, from the 80s and have old worksheets pulled out of some workbook from God knows when. But some of the science that exists, I'm very interested in the neurosciences, neuroscience, epigenetics, adverse childhood experiences, and resiliency is what that stands for. But how do we actually teach people and help them understand the impact of trauma on their own brains, and how can they rewire their neural pathways in a much healthier manner? Are we teaching about the science of hope? Like, turns out you can actually teach how to engender hope in a human being, and hope is absolutely necessary for sustained recovery. Are we teaching that? I don't think we are, but there's a lot of stuff about the science of hope that we could be infusing into treatment. Are we helping people goal set and create a life worth living? Are we helping people imagine and dream while they're in treatment about careers? And I don't think we're doing a lot of that, and it's just a missed opportunity. And the science exists, we just haven't paired it with treatment. And then the last thing I'll say kind of hovers between treatment and recovery support services. But back in the day, when probably 10 years ago, when I used to sit on King County Behavioral Health Advisory Board, they used to talk about this concept of interim services or interim beds, and they got cut. They haven't existed since before the recession. But this, like, people have a gap between withdrawal management and inpatient treatment, or a gap between inpatient treatment and recovery housing. And some of our amazing, recovery coaches and people in community get hella creative, and they couch people at Oxford houses, and they, use their ingenuity and grassroots connections to basically come up with stopgaps. But could we potentially use that same single family home model to do transition housing? I know actually Linda Grant up at Evergreen Recovery Centers has got one, and I actually want to find out how she's paying for it. But I'm really interested in that model, less than going to be less than a 2-week stay, if not substantially less. But man, the return on investment is very high when you actually, house someone for a couple, 3 nights, 5 nights, so that they have a seamless transition instead of dropping them on their head, which is their current practice. That's all. Thank you.
Thank you, Lauren. Rob Davis. There's a lot there, and we'll try to put your comments in the right buckets there a little bit. But you're right. Interim services was a thing. I mean, it was. We did regularly. A lot of it was outpatient check-ins until you can get into residential if you were waiting. But what do you do in the evening? Where are you laying your head? Do you have a place to lay your head? Things of that nature are really important. But I think you've teased up quite a few things there in terms of, let's really challenge ourselves to look across the state, look across the country, look at private and public kinds of strategies globally, and see what it is that we might want to take advantage of here. We have a couple more minutes. Caleb, you put quite a few things in about low barrier access to treatment, which is something that we certainly want to see. I mean, ideally, right, we would have real-time treatment access, low barrier pathways in, things of that nature. Caleb, do you want to say a couple words about that before we transition over to recovery support services?
Sure, thanks, Michael. I think the issue with low barrier that we see continually as someone who's worked in the treatment system and in the healthcare system is that those are incredibly high barrier places. And for decades, we as a system perpetuate that same system and do more of the same. That's what we know how to do. That's what systems do. And in the work we've been doing, asking clients who are using substances out in the community, there's a lot of stigma, and off-putting is a gross understatement for what healthcare and treatment is like for many people. I don't know what the number or ratio is. I just don't know. But my gut says to me, probably at least a third of people with SUD in our state need care in non-formal treatment systems, sort of out in the community in low barrier settings. And those are the same people with some of the most trauma, the longest histories of use. In other words, they're probably at the highest rate of more risk for mortality. You know, you might have 30% of people who might represent 60% of mortality. I don't know if those numbers or proportions are correct. The epidemiologist bone in me feels like it's something on that scale. And so I just, as we're thinking about how to make our systems better, I think we also need to really think about this low barrier nature of engaging with folks. And Rep Davis has talked before that pre-treatment doesn't actually mean that treatment is your goal, that that's not what you're going towards. We're trying to look for reduction in harm. We're trying to look for improvements in quality of life. We're trying to look at recovery. For some people, that's the formal treatment system. That's what we know. That's what I was trained in. That's what so many of us were trained in. But it needs to be a lot more than that. And that's the hope of this legislation to me, that I hope would be realized with this LEAD model, with this harm reduction emphasis, with this language around low barrier, is that it's not scaling up more of the same, that it really is trying to think about, honestly, just a customer service orientation. You know, how would we maximally engage the most people? It's hard to scale. It's very hard to scale and think about how you stand that up. It's like taking a gazillion pop-up clinics. There's just not a lot of stability there. So that's why I was talking about these things earlier about the data systems, which, you know, are great in theory, and all the infrastructure that we have to help support people. But it comes down to, you know, Hallie's list of the 30 people in her cell phone that she knows who to call to figure out what the wait list really is. And so it's a lot of people, it's a lot of resources, it's recovery support, it's peer recovery folks, it's all of those people. But it's just how do we create that? It has to be our goal. And I think we have to think about, ultimately, the public health person to me is like, I don't want people to die. The social worker person to me wants quality of life and a return to functioning. And how do we really work towards those goals? And again, not just sort of perpetuating our existing systems and just think how to scale those up.
Thank you, Caleb. Appreciate your insight there. Hallie, it looks like your hand is up. Is that a new up? And go ahead, and I'll give you the last word, and then we'll move over to Recovery Support Service.
Thank you, Michael. I know I talk a lot, and I kept my hand down for a minute, and I was like, I just can't. So, yeah, I have a lot of thoughts, and it's coming off of a number of people that spoke before me. I'm just going to try to run down my list real quick as I was thinking my way through it. One was the housing piece, looking at housing from a harm reduction perspective and how we can create housing that isn't contingent on someone's sobriety, I think is key. An issue I'm running into, and I would imagine I'm not the only one. So we're a small nonprofit. We're working on adding co-occurring services, true co-occurring services. We found the unicorn as far as a clinical supervisor, but there aren't any resources that I can find to help us build this piece of it. And that would be really helpful, because those of us that are more nimble and able to pivot and spin also are more in need of help and support to create new programs. So I think that's something to look at. Street outreach, I think, is extremely important. We do that. We receive no compensation for that. So as a small nonprofit, we're just doing the next right thing while struggling financially. So I think looking at how to support that, because I think when we think of continuum of care, street outreach is the starting point. And that's building relationships, building trust with people who have no reason to trust anybody at this point. So I think that's really important. What Caleb said about withdrawal management for people on fentanyl, from our perspective and what we're seeing out on the streets right now, that's super crucial. So I think that is, and it's going to become more crucial based on what we're seeing. Services for uninsured and underinsured individuals. Like right now, our agency, our nonprofit, sees people on Medicare for outpatient services, and we do it for free because Medicare doesn't cover that. And so 30% of the people we're seeing are completely free. We don't charge anybody, we only bill Medicaid. So looking at underinsured populations, we're super vulnerable. Contingency management, I think that is absolutely crucial. We were doing it for a short time. I know Caleb's working on a project with that. Again, that was something that we were doing without any way to bill for a service, just doing the next right thing and figuring out how to get that going more because it's such a positive reinforcement situation. So not wanting to rebuild the same systems we have, but we do have some things within our systems that work. And one of the things that I see that works is 3.1 level of care, which can be a 3 to 6 month inpatient. We have 2 of those in Spokane, one for men, one for women. They both can have up to 15 individuals in at one time, and they're there for 3 to 6 months. So that's not a lot of people they can see in a year. They're always full. It's true co-occurring. I think getting more of that in place because we have time to get housing, employment, and those things in place before completing treatment rather than doing that spin dry and straight out 2-year-old situation. So, and then how do we all collaborate to tie this all together so that we're not working in silos? And how do we collaborate so that we're sharing information and educating each other on new opportunities, new treatment models? And then I wanted to address real quick what Representative Davis said regarding there's a lot of scientific information out there that could be put into use. And there is, but I think one of the struggles, and I'm just coming from my own limited experience, but one of the struggles is that from a cost perspective, we don't receive enough funds for the services we provide to be able to invest in the training and resources and so forth to even bring forth these other options, even though they should be brought forth. So there, I'm done.
Thank you, Hallie. Really appreciate, again, giving it thought to the questions at hand. We're going to move over now. We've talked a little bit about this, but looking at some of the social determinants of health, recovery support services, peer work, housing, employment, education, transportation, childcare, all the things that we need in our state to help support those in recovery. And our challenge is to look at all of our residents, all of our citizens and residents and people who live within our borders or travel here. Not Medicaid dependent, not public assistance dependent, with or without insurance, but how do we set up really good communities to support those in recovery? And I'm just looking here, Cheryl, John, Sarah, Alex, there's a few folks here that we haven't heard from yet today. So I'd really ask you to think about what you would like to see in your communities that are not there now, or more of what is there to help those in recovery sustain their recovery. And so give that some thought. I certainly, we want to continue to hear from everybody, but if you haven't had a chance to speak up yet today, or if you have some real driving thoughts on this, please let us know what you're thinking. You guys have been talking a lot about the need for housing, so maybe start there. But what else is there? We've heard that we have Oxford homes. We have more Oxford homes than any state in the country. Do we have enough for women who need their children with them, or men who need their children with them? Or, you know, do we need family Oxford homes? I mean, let's think creatively and beyond Oxford homes, obviously, for other kinds of models that are out there too. But again, housing, education, employment, all those things that are so important. Please let us know what you think we should put in our plan forward. And I think it was mentioned here a minute ago that doing the next right thing. And I heard that and I thought, you know, maybe that, Hallie, you might have said that, we're out doing the next right thing. That may be the title of our state plan is doing the next right thing. So I really like that a lot. Let me look for hands. I don't want to miss anybody here, folks. Amber, your hand is up. thoughts about recovery that you haven't had a chance to share as of yet?
I did write down a couple things. I am a peer support specialist. That's my job. So I know I wanted to let everybody else share too, but nobody raised their hand.
No, speak up, please.
Okay.
Please. I'm encouraging
So
everybody.
I work at a recovery community, and I realize that there's dollars for recovery communities, but there's so few recovery communities in the state. Anyways, we're actually a 501c at this point, but we're looking to become sustainable because there's no way that, we have been around for a while as a result of grants and donations as a grassroots organization. But in order for us to expand recovery support services, we need to become sustainable. It's my recommendation that we create a new designation for recovery communities as far as recovery support services, because it doesn't fit into a treatment model, and it doesn't fit into, really the nonprofit model, because it has to be sustainable, right? And there's little money for recovery communities right now, but there's not a way for it to be sustainable. And the reimbursement for peer support services is so nominal, it's almost not worth it for us to charge Medicaid. And also, as far as housing goes, what you were talking about, there's nothing for non-custodial parents and singles as far as help. It's a passion of mine. I've talked about this before, that there's, parents that don't have their kids, that they really need that support of, long-term transitional or permanent supportive housing, so that they can, remain in recovery, keep their job, have a place to visit their kids. Those kids have a right to both of their parents. And recovery support services are really lacking for the parent that doesn't have the child full-time. Also, families, most shelters won't accept families, as far as, especially if they're not married, because a lot of shelters are faith-based. The only one in town here that accepts men at all is faith-based. And my brother and his wife had to stay separately. Her and her kids on one side of the street and him on the other. And it was really sad. And there's nothing for men with children, right? And especially for people that are on medically assisted treatment. We do have a couple of Oxford houses here, but it's up to them democratically if they want to accept people on medically assisted treatment. That's how Oxford houses work. So they have to vote on everything as per, the individual house. There's no standardized model for housing for people on medically assisted treatment. And I would also just like to say, I just reiterate what I put in the chat, that I would like to see a more recovery oriented system of care for people. And that doesn't always mean abstinence completely. So the treatment model, we do need treatment, and we need more accessible treatment. But those supports before and after that continuum of care to support long-term recovery is really lacking. Yeah, that's all. I'm going to shut up now.
All right. Thank you, Amber. We're going to give you the last word on this in this forum. I'm looking at a second screen that has the agenda. It didn't have the public comment period on it. So we need to stop now and take public comment, because we may in fact have additional thoughts about outreach, treatment, and recovery supports from those that have joined us here today. And we'd love to hear from them. So I don't want to shortchange that. As members, if you have other thoughts of what you'd like to see moving forward, please continue to have that information sent in to us. And if you're a little shy today, or kind of getting your wits about you and think of something tomorrow or later in the week, send it in. We want to continue to have this conversation moving forward. At this point, we are going to move to public comment, and the topics can range from anything we've spoken about today or anything new that you want to bring up. But if you're so inclined, you want to give some thoughts about what you'd like to see around outreach, treatment, and recovery, we'd love to hear from you all. So let's go. Let's see how we're going to do this. Do we have somebody signed up yet? Michelle, to any of our guests that want to speak as of yet?
I haven't seen anyone say they wanted to comment in the chat yet. Oh, sorry, Lisa, go ahead. And anyone else that would like to follow, please raise your hand and then we'll know, unless you're on the phone, and then use the chat, I guess. Thanks.
Perfect. There we go. I'll look for hands. So go ahead, Lisa.
Okay. Hi there. I appreciate this chance and will probably reliably offer the same observation in a lot of your meetings. We, chronically do not provide enough care or the right care to most people who struggle with behavioral health issues. And all of your contributions to this discussion today have emphasized the ways in which that's true. I just want to underscore, many of you know that I come out of the criminal legal system reform world, not the healthcare world. Much is known about how all of the things that are wrong with the way that we provide healthcare in America are quadruply missing or poorly designed for the population that instead gets pulled into the criminal legal system, not theoretically, but actually. And so, those patterns are racially defined, but they also coincide with many, many other axes of marginalization, lack of resources, and intergenerational harm and trauma, which is, of course, greatly compounded by having used the criminal legal system to respond to some people's health issues, but not everyone's, for all of those decades. And so I just would ask that this group intentionally always make sure that there is an added lens in the design of any interventions or strategies to increase resources or increase access, to make sure that those channels work for that population that has been primarily engaged by the criminal legal system with respect to behavioral health needs. The system modifications that are needed to make that work look different than they do for comparatively more affluent, and these are all gross generalizations, but comparatively more affluent people whose families have more resources, people who have a little bit more economic resilience, and people who are on the whole whiter. So if we can make sure to design for that population that has been systematically estranged from the healthcare system for other reasons besides just having behavioral health conditions, that will facilitate the paradigm shift we need to see from the criminal legal system's always there. When this kind of approach fails, it's going to show up and point to the failure of this kind of approach as reason that we have to put people in jail and we have to prosecute people. So please provide the strongest possible rebuttal to that paradigm by making a system that actually works for that population. Thank you.
Okay. Thank you, Lisa. Other guests have comments for us today for the panel?
Jessica?
Hi everyone, this is Jessica Bloss from Healthcare Authority, also our state's opiate treatment authority. And I just wanted to announce more support for some things that we've already been discussing, improving the quality of care. I guess I should start off saying there's lots of existing strategies that I feel like our state is well in support of, but we could still continue to do better jobs at. One would be improving the quality of care. In physical health care, we expect there to be positive outcomes. If someone, breaks a limb and they go receive care, then there's an expectation that that person is going to, heal and get better. And I think we could do a lot more to look at outcomes and require more for the use of evidence-based practices and actually have higher expectations for that quality of care in behavioral health settings. I know our state is already doing a lot of work to help integrate care in behavioral health and physical health services. But again, there's still so many comorbidities that our behavioral health and SUD patients are exposed to We're having more access to co-located or care coordination with physical health services to address everything from wound care, infectious diseases, STIs, STDs. You know, these things are really important and we could do a better job. I put some comments in the chat, you know, continuing to improve access to care in different settings for individuals who take medications to treat opiate use disorder. This would be methadone and buprenorphine patients. You know, we still have tremendous issues in our state with a number of settings, whether it's state hospitals, correctional settings, behavioral health, residential treatment settings, shelters, recovery residences, allowing admission to individuals. I wonder if there could be regulatory or financial incentives that could be pursued to help improve access to care. And then lastly, I just, again, voicing support for better integration of harm reduction strategies and pre-care to the continuum of care, thinking about things like ambulatory withdrawal management, and then just really more opportunities for almost aftercare. Like, what does that really look like? Should we, you know, recovery is a lifelong journey. We need, I think, to just have more services that meet the variety of places where people can be at mentally and physically. Thanks.
Thanks, Jessica. Any other guests here today who would like to give public comment to the planning process, I should say? Okay. Members, anything else you'd like to share today before we move on to next steps and adjourn?
I would like to know if there's a way to save this chat. There's a lot of good resources in it, and and links that I want to explore at a later date. I don't want to lose them. And I don't see the 3 dots in the bottom corner, so I'm like, what do I do?
Yeah. I think, Michelle, we're able to capture the chat, are we not?
Yes, we are. I think it, yeah.
Okay. Thank you, Amber.
Mm-hmm.
All right. I would like to thank Kira for getting on today. I think it was her first meeting. Certainly Kevin for joining us, for our local government representative, and Hunter, thank you for being our first youth voice on the committee. I really appreciate you taking time out of school today to join us, and tell your teachers you did well, that you got good feedback. So with that, I'm going to turn it back over then to Michelle to kind of wind us down. Anything we want to say about next steps or next meeting before we adjourn?
Yeah, just in terms of next steps, if there are more comments or suggestions that you didn't get to during this meeting, please email me in response to the notes, and I'll be sure to, or before the notes really would be better actually, so I can incorporate those. And other than that, the next step is just to review the recording if you have a chance, the notes, and I'll be sending those out in the next couple weeks, but otherwise there's no set next steps or actions to be taken at this time.
All right.
Yeah.
I guess before Senator Dinger is in committee, otherwise she kind of gives us a little recap from month to month, so or charge, I guess. With that, thank you all. Enjoy your early February day. It looks like we're going to have sunny skies across the state this week, so have a great time, and thank you for all your contributions. Very helpful today. Take care.
Hey, Rachel, can you stay on for a second? Yeah, I'm still recording the chat. So
okay.
yeah, I'm just gonna mute myself though.
Okay.